Right. Good afternoon, everybody, and welcome to this afternoon's IBD Gecko session. Gecko is, of course, hosted by the Gastro Foundation in association with Project ECHO, University of New Mexico. These sessions are held weekly on a Wednesday, and please, the chat will be open for questions at the end. So I'm going to start off with just a brief overview of thiopurines and their role in inflammatory bowel disease. And after that, I will be followed by one of the fellows in our unit, Dr. Moosa, who's going to present a case around thiopurine use. So I'm just going to start sharing my screen. Okay, Cheryl, can we see it?
Good.
You can see it?
Yes.
Full screen.
Yeah.
Okie dokes. All right, so thiopurines are obviously a class of drugs with immunosuppressive activity, and they have a very complex mechanism of action. Firstly, they act as rogue nucleotides, and they're incorporated into the DNA chain, inducing T-cell apoptosis. A second, more recently recognized mechanism is that they inhibit an enzyme called RAC1 GTPase, and through a number of different steps, ultimately, this impairs the interaction between T cells and antigen-presenting cells, producing immunosuppression. There are 3 thiopurines that are commercially available, as a thiopurine and 6-mercaptopurine, and then in some other regions around the world, 6-thioguanine. These drugs take about 8 to 12 weeks to work, so the role is really in the maintenance of a remission rather than the induction of remission. So how effective are they in Crohn's disease? Well, a meta-analysis of 6 studies with almost 500 participants as a thiopurine was shown to be superior to placebo for maintaining remission over a 6 to 18-month period, 73% on as a maintained remission versus 62% on placebo. But if one looks there, the number needed to treat is 9, which is obviously fairly high. And this is read to the latest ECHO guidelines, which is still to be published in full, suggesting that thiopurines may be effective, but that clinicians should consider their side effect profile and the availability of other therapies. They are very good in preventing post-operative recurrence of Crohn's. A network meta-analysis showed that they decreased short-term 1-year clinical and endoscopic post-operative recurrence, and a Cochrane review of close to 1,000 patients showed that they were superior to placebo in reducing post-operative recurrence, with rates of 51% versus 64%. But not surprisingly, in this Cochrane review, they were inferior to anti-TNFs for reducing post-operative recurrence. I think when one is looking at using thiopurines in patients for the purpose of preventing post-operative recurrence, one needs to really identify those patients who are at high risk. And these are the young patients, smokers, patients who've had many surgeries, penetrating disease, perianal disease, a short duration between diagnosis and first surgery. And in this particular high-risk group of patients, thiopurines should be started within 3 months surgery. In fistulizing Crohn's disease, they may work, but there's not very much data, and really they are not comparable to the biological agents. And if they are used for complex fistulae or internal fistulae, they really should be used together with an anti-TNF if it's available, and infliximab, of course, being the one that there really is the main bulk of evidence. In ulcerative colitis, there's much less data than in Crohn's, but a Cochrane review of 4 randomized controlled trials of at least 12 months duration of thiopurine therapy, they were significantly superior to placebo with about a 20% delta. And so the ECHO recommendations on thiopurines for ulcerative colitis are a little bit stronger than they are for Crohn's, and they do make a recommendation here for their use in steroid-dependent ulcerative colitis or patients who are intolerant to fiber-aminosalicylates. So in terms of dosing, at present in South Africa at least, I'm not sure about the rest of the continent, we still use weight-based dosing because therapeutic drug monitoring of thiopurine metabolites is not available locally. And we tend to use 2 to 2.5 milligrams per kilogram of azathioprine and 1 to 1.5 milligrams per kilogram of 6-mercaptopurine. This is not ideal at all, this weight-based dosing, because the metabolism of thiopurines is not uniform. It differs enormously between individuals. But there are some clues on a full blood count that the drug is therapeutic. lymphopenia, and an MCV raised above 7 from baseline. The adverse effects of thiopurines are many, and they can be divided into two categories. Firstly, dose-dependent adverse effects. These are predictable, pharmacologically explainable, and are due to the production of thiopurine metabolites, and they can occur at any time after starting therapy. The second are idiosyncratic reactions, which are unpredictable and dose-independent, and they typically occur within 2 to 4 weeks of therapy initiation. Here are some of the more common complications of thiopurines. GIT upset with nausea and vomiting is by far the most common. Myelosuppression, particularly neutropenia, the one that we're all most scared of. Infections, particularly viral infections. Hepatotoxicity, flu-like symptoms of myalgias, arthralgias, fatigue, fever, and the most important of the idiosyncratic reactions, pancreatitis, and then, of course, thiopurines confer an increased risk of malignancy. So this is the pathway for thiopurine metabolism. Firstly, azathioprine is metabolized to 6-mercaptopurine, about 90% of it is. And then it's further metabolized through 3 different pathways. The first is by xanthine oxidase to produce thiouracil, which is an inactive metabolite. The second, The second is through thiopurine methyl transferase, which metabolizes to 6-methylmercaptopurine. And the final pathway is HGPRT with a number of other enzymatic steps, which ultimately result in the production of thioguanines. And the most important one there is 6-thioguanine triphosphate, because this is the thioguanine that is inserted into the DNA chain, and it's the one which causes that RAC1 GTPase inhibition. So some of the complications of thiopurines are due to defects in the metabolic pathways, notably hypermethylation, TPMT deficiency, or NUD-T15 loss of function mutations. Firstly, the hypermethylators. These are individuals who have high levels of TPMT activity. As such, the 6-mercaptopurine is preferentially metabolized to methylmercaptopurine, which shunts it away from the 6-thioguanine pathway, so you get lower levels of 6-TGs. And this has resulted with reduced efficacy and increased side effects, notably hepatotoxicity. So there are really 3 forms of hepatotoxicity that one can see with thiopurine therapy. The first and most common is a mild, transient, asymptomatic rise in serum AST and ALT, particularly with high doses during the first 12 weeks of therapy. Second, very uncommon, acute cholestasis during the first year of starting therapy. And then finally, chronic hepatic injury, typically 1 to 5 years after starting treatment, pileosis hepatitis, veno-occlusive disease, and nodular regenerative hyperplasia. These are all very uncommon. Secondly, the TPMT mutations. Now, there are over 40 different variants of TPMT. Most of these variants are associated with lower TPMT activity. The 3 common ones that cause loss of function are TPM2, TPMT3A, and 3C. And about 1 in 300 individuals are homozygote for these mutations. 1 in 10 are about heterozygotes, and the rest are wild type. Low TPMT will obviously cause shunting towards the 6-TG pathway, increasing levels with a high risk of neutropenia. Finally, there are the loss of function NUD-15 variants. This is an enzyme that hydrolyzes that final thioguanine in the pathway, which is the 6-thioguanine triphosphate, which is the subtype that's incorporated into the DNA and that inhibits the RAC1 GTPase. And it's encoded by the NUD-15 gene. And in recent years, it has come to light that there are loss of function mutations which lead to higher levels of the thioguanines predisposing to myelosuppression. This is particularly in Asian populations. We don't really see it in other populations. What about malignancies? Well, of all IBD medications, thiopurines confer the greatest risk. There is an increased incident in incident cancer rates. This is especially in the older IBD patients, where I have highlighted with the red circle. They're mostly urinary tract cancers, lymphomas, and non-melanoma skin cancer. The most important of the lymphomas is a post-transplant-like EBV B cell lymphoma, and thiopurines increase the risk of this lymphoma by 5-fold. The risk typically becomes significant after 1 year of exposure to thiopurines, and the individuals that are most at risk is men younger than 35, but the highest absolute risk is in patients over the age of 50, where the risk is 1 in 300, which is considerable. There are also two other forms of lymphoma that can occur as a consequence of thiopurine therapy. The first is hepatosplenic T-cell lymphoma. It's a very, very rare cancer linked to thiopurine use. And it has been linked either as monotherapy or thiopurines used in combination with anti-TNFs. And it's, again, usually young males, and it's usually fatal. And finally, there are patients who are Epstein-Barr virus negative, who, when they develop a primary EBV infection, are at risk of developing a rapidly progressive lymphoproliferative disorder resembling hemophagocytic lymphohistiocytosis. Again, this is essentially young males, and again, it is often fatal. What is interesting about thiopurines and lymphoma, as you can see, again, highlighted with the red circle, is that the moment you discontinue them, the risk of lymphoma reverts back to an individual who has either never used them. In contrast, the risk of non-melanoma skin cancer remains, regardless of whether you discontinue. So even if you discontinue, patients always need to be aware and ideally have regular dermatological checkups. So how can we reduce the risk of complications, and how can we manage these complications? Well, firstly, the GIT upsets. This may resolve with switching from azathioprine to 6-mercaptopurine. Other things could be starting with a low dose and titrating up slowly, or split dosing. This is where you split the dose into morning and evening. And the rationale behind this is that it keeps the peak serum concentration of 6-mercaptopurine below the threshold substrate affinity of TPMT. So it reduces the methylmercaptopurine levels. Flu-like symptoms, the myalgias, arthralgias, fatigue, and fever, a similar approach, either switch to 6-MT, split dosing, or try incremental dosing. To prevent infections, all patients should have an opportunistic infection done before starting a thiopurine, and I highly recommend that this is done in all patients at the time of diagnosis, regardless of what therapies they're on. And we do an HIV, Hep surface antigen and antibody, varicella zoster IgG, EBV IgD, and a chest X-ray. And wherever possible, you should vaccinate for varicella zoster, hepatitis B, influenza, pneumococcus, and human papillomavirus. In terms of myelosuppression, one wants to check the TPMT genotype at baseline. The phenotype, which is the actual activity, can also be checked, but we don't have that available, so we use the genotype. And if patients are homozygotes for those mutations, or they have very low activity when checking phenotype, thiopurines really should not be used. If they're heterozygotes or they have intermediate activity on phenotype testing, half doses can be used. One must check the white cell count at baseline, and then at 2, 4, 8, and 12 weeks. And then if everything's okay, they can have their white cell counts monitored 3 monthly. Just to point in mind, 50 to 75% of all patients developing leukopenia have a normal TPMT. So monitoring is long-term. Metabolite testing is best practice where it is available, and in many countries like in the USA and the UK, this is routine. And it is the measurements of thioguanines and methylmercaptopurine in red blood cells, usually after a steady state is reached at 4 to 6 weeks. And one aims to achieve thioguanine levels between 230 and 450. This is sort of what we do when we encounter myelosuppression. If you've got a white cell count that's marginally decreased, if you live elsewhere in the world, you can measure the metabolites and adjust accordingly. We tend to stop the drug for 1 week, and if the full blood count normalizes, then restart at a lower dose. If, however, you're getting to levels of a white cell count less than